Thanks, everyone. And a reminder that if you are messaging in the chat, letting us know where you're from or posting comments or questions, to make sure, please, that you choose the chat that says everyone and not hosts or panelists so that we can all see that. Thank you, everyone, for joining our March webinar on working with youth who use substances with Dr. Sharon Cirone. Can you advance the slide, please, Lori? Thank you so much. I will start with our Medify land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The work of Medify and our partners takes place on traditional territories of the Indigenous nations who have lived on these lands since time immemorial. The Medify program is located in Toronto on the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Atawendurons. This is Dish with One Spoon Treaty Territory. Medify is committed to reconciliation. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect and embrace the rich cultural and traditional practices of the ancestors. We invite our partners to reflect on the territories where they're situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Next slide, please. Thank you. So this is a chance to acknowledge our scientific planning committee, share their disclosures. I'll give everyone a minute just to see where any honoraria have come from. And also a chance to thank everyone who's participated in planning our webinar series. And then the same people who plan our conference. So they're a great education committee. Next slide, please. Thanks. And just a moment to see the conflicts of interest. Great. Thank you. And again, we're grateful to have received financial support from the Ministry of Health as base funding for Medify, which supports this program, as does in-kind support from Women's College Hospital. Next slide. So I already mentioned, please use the everyone chat box for any of your comments or questions. I'll be following in the chat and collating questions for the end. If there's something that's really pressing, I will interrupt Sharon, but otherwise we'll save them. And at the end of the talk, you can raise your hand and Lori will unmute you if you want to ask your question or engage in a conversation with Sharon directly. There will be a session evaluation linked at the end. Please do complete that. It is really helpful for us to get feedback and in terms of planning, although I know the session is going to be great. Next slide, please. And on I already acknowledged our webinar committee members, so we can skip to the next slide. Just a lineup of webinars coming up through the rest of this calendar year. We're pretty close with a break in the summer. In April, we'll be talking about managing substance use care in the acute care setting. May talking about heart hubs, which is feeling like it should be an interesting talk if we can have it at that point, and more withdrawal management. And of course, a reminder that the conference is just a month from now. So please register if you haven't. We'll be putting up the registration links for those who are going to join social hubs being hosted in Toronto, Hamilton, and London. Next slide. Great. Okay, while Lori gets Sharon's slides up, it is my privilege to introduce Dr. Sharon Cirone, who is a family physician with a focused practice in mental health and addiction medicine. Sharon provides care in remote First Nations communities in the Sioux Lookout region of northwestern Ontario. Her clinical care has included service in urban and rural practices in both inpatient and outpatient settings for all ages, but with a focus, and I would say a passion, for adolescent and youth populations. She enjoys the engagement process with young patients, the challenge of creating youth-friendly environments, and also the rewards of working with this population over time and into adulthood. And personally, she's been a mentor for me in terms of working in Northwestern Ontario and engaging with First Nations communities in the work that she does up there. So thank you, Sharon. We're so grateful to have you.
Thank you. Thank you for the introduction, Jen. So I suppose you see me in a speaker image. Welcome, everybody. I see that there are people in the audience that are dear colleagues and friends. I'm really excited. The thought of us all being together in this one time is really lovely. And you may see the image behind me if you see a speaker's image. This is where I am so fortunate to fly over several times a month into the boreal forest, working with youth for sure, but people of all ages. And there are people on the call here who are really skilled and highly experienced at working in the North, as well as particularly working with adolescents and youth. So welcome to everybody. I'm hoping that you engage in conversation. A lot of what I'm presenting is familiar to you, but it allows us the opportunity to have a conversation together, I hope. We'll just go to the next slide. I have nothing to declare, and oh, I made a spelling error. I have that to declare. I have no fiduciary relationships that I need to mention, and I will in fact be making off-label mention of medications. And in the next slide, I'll just jump right in and suggest that when we're talking about adolescents and young adults or youth, and the substances that they're using, and what we might see for many of you, you work in a RAM clinic, but that's not the clinical setting for everybody. I do see quite a few colleagues from the North on this call, and so many of us work in primary care settings or comprehensive clinical care settings. And so we see youth that come in with a variety of different experiences, stories, and substances that they may or may not have just initiated or are using to the extent of it becoming problematic. Very rarely does a young person come in the door and say, I have an addiction. They self-identifying as having an addiction disorder or being an addict is not usually how young people present. They usually present having tried the whole menu, a myriad of substances, including over-the-counter substances like we're seeing in the images here. Dextromethorphan substances are very common from over-the-counter to substances that they wouldn't even know, it was an orange pill, it was a blue pill, more novel substances. I'm going to say these manufactured cannabinoid substances like the spice product that you see. These are no longer novel, but there are other novel substances that youth are buying off the internet. But as usual, the ones that have been popular throughout history remain popular. Although alcohol is used a lot less by this younger generation than my generation or the generation before them, it still remains high on the radar. We can go to the next slide. And so the Ontario Student Drug Use Survey, the OSDIS survey, the most recent was from 2025. Probably most of you have heard of this survey. It's one of the largest, most comprehensive surveys in the country. It's been running since 1977. Its limitations are that it interviews students, so those who are actually registered in a school, attend school at the time of this survey being carried out. So you can imagine that these numbers don't reflect all of young people. And it's been done every 2 years since 1977. In 2025, it showed still relatively high numbers of youth that are using alcohol, or what the question usually is, in the last year, have you used? And then the substance is named. So in the last year, 38% will have used alcohol and 10% are quite actively binge drinking. Those numbers would have been higher in the generations of the people who are on this call as an audience member. And that even affects our ability as parents or grandparents or aunties or uncles to have these conversations with the young people that we see. Cannabis use is relatively high, but as we all know, at a totally different strength of THC than in our generation. Vaping is higher than even actual tobacco initiation. So some of the numbers are high. And what's the newer kids on the block are the ones that are non-substance use or behavioral problematic use of a variety of different platforms, and some of which become addictions. So you see gambling, video gaming, and social media as things to be taken in consideration. Lots and lots of discussion out there, isn't there, on how early exposure to social media use, excessive social media use, is actually physically changing the brain on so many levels. We have more to learn about that, and the literature around to what extent that is a direct entry, or remember that term we used to hear gateway, when they talked about cannabis taking you straight to heroin. And to what extent is social media platform problematic use, excessive use, and even addiction a gateway to substance use? The literature is not very robust on that yet. We can go to the next slide. As far as opioids go, which might be a more common reason for people who come into RAM clinics or into any of the clinical settings where you work, again, it's the norm is having tried a variety of different substances, and often not having established a favorite opioid at that point yet, and not even actually having continuous use or even daily use. So they may have novel opioids that most of us in this crowd have heard of, but that other providers or parents might not have heard of. Kratom is a really good example. A lot of these are sold, over the counter, under the counter, black market, so to speak, or on the internet. Imodium is used. A good example is there's pockets of use, right? Because there's adolescent influencers, and I don't mean online influencers, just local peers. An example was there was a period in Sydney, Nova Scotia, where there was a whole crisis around adolescents coming into the emergency department affected by Imodium and the opioid-like effects of Imodium. The patterns of use are very different in adolescents, generally speaking, than in adults. As they start to get into the young adult or youth ages in the early 20s, patterns that are more typical of the adult population that we see. But in the younger ones, with difficulty to access of use, they get it sometimes from their parents' medicine cabinet, sometimes online, often not using on a regular basis, as I mentioned, and sometimes not even intentionally. They're just taking a tab from another friend, and they don't even realize that it's an opioid. And so just to plant a seed in the back of your mind, if the setting you work in is an opiate agonist treatment clinic or a RAM clinic, and your go-to tools in your toolbox are very often opiate substitution therapy, just the consideration of, would you even consider opiate agonist treatment for a youth who's not yet fully dependent, but is just trajectorying into, and maybe even very high risk with their opioid use, but not necessarily fully dependent yet? Knowing many of the clinicians on this call, many of you have sat with this discomfort in your gut and in your clinical decision making. We can go to the next slide. How does this look if you consider your setting? Many of you actually work in a variety of different settings, don't you? Not just in a RAM clinic, not just in a primary care setting, not just in a social service setting. And how can we adapt? Even if your setting already has adapted, how could we adapt more? What can we talk to our team about being even more, bringing more developmentally appropriate services to this population? What kind of screening tools can we use, or assessment approaches can we use that might be different than we would with adults? Is it innovative to use, I think a lot of the opiate agonist treatment clinics, or to use this, tablets in the waiting room to start gathering information? Now, many of them do that in order to maintain the volume of patients that they can see, but you can also use it to have an innovative way for a youth to fill out an assessment tool to get an idea. And I'll go into the specific tools that are really useful with young people. And what kind of other youth specific approaches can you use, specifically treatment approaches? Um, I've definitely learned in this line of work, in so many different settings where I've worked with youth, that the most important medicine, if you will, the most important modality, the most important tool that we'll use is the rapport development that we engage in, that we lean into, the therapeutic alliance that we build. These are important. One of the audience members started an opiate agonist treatment program in. Oh, gets me, May, in a high school for in a high school setting, in a high school clinical setting for youth in Thunder Bay, and what a brave and fantastic idea, and what a great place to meet them where they're at. So these are some of the adaptations that we're talking about, and that's an example of somebody who's done something very monumental. We can go to the next slide. And so, to remind us, all of us have been in this position ourselves. We have watched nieces and nephews and kids and grandkids go through these stages. The literature has talked quite a bit about even the popular literature. So here I have a National Geographic edition that's actually quite dated now, talking about the development of the teenage brain. And we're given sort of blanket statements like probably the brain continues to have development until the mid-20s, so age 25 is often what I'll use when I'm talking to a young person about some of the decision making they're engaged in, or when they're asking me, access to cannabis documentation. I try to point to an age of 25 as a time when their brain is still developing. Most markedly, their forebrain is still developing. So what we see is a lot of changes, but mostly the changes of executive functioning, of decision making, that come online at different times. Boys different than girls, different cultural influences, influences of our own home life, and certainly progressively over age. And so it might look organized like we see in this slide with these PET scans that are really nicely displayed. We'll go to the next slide. Or maybe in reality it looks a whole lot more like this. Some of you have seen this slide before, because I gladly, having received permission from the author, use this in a lot of my presentations, because this is this is maybe a little bit more reflective of what it actually looks like in the teenage brain, and trying to negotiate on linear terms or from the adult brain with the youth brain is not an easy task. I'm going to take us actually, please, to the next slide. So with all of that in mind, we have a lot of tasks that we can imagine the youth brain, the youth life, the youth experience is going through. There are a lot of sequential neurodevelopmental tasks that are really important. You learn to write a sentence before you write a paragraph, before you write a thesis and an essay. Right? And that's repeated in math, that's repeated with math skills and with socializing skills and finding a girlfriend or a boyfriend skill, or finding, employment skills. So there's so many tasks that they're going through that impact all kinds of decision making, what relationships they're engaging in, what sexual relationships and decisions they're making, their engagement in prioritization of which activities are important for them. And for some people, more and more so in this age group, making decisions through the cloud of many other priorities and realities, like neurodiversity, gender issues, sexual orientation issues, othering issues at school. And for some kids, I worked for a very, very long time with a population that was homeless and street involved. Some of their issues are just sheer survival survival. So um, I think many of us on this in this audience have worked with a wide variety of young people at ages, population ages, but also people from a variety of different backgrounds, and to sit down with each youth and take the time. We were talking about this in preparation for giving the talk today. Sometimes we need to slow down to go faster or to do our work in a better way with young people, to sit down and take the time to not just take an adult oriented drug use history, but to actually parse out some of the neurodevelopmental tasks that are important for adolescents to meet. We'll go to the next slide. And to take into consideration, I'm going back to the OSDIS survey from 2025, that much more so than our generation, young people are speaking to the burden of mental health issues they have to deal with. This doesn't necessarily mean a diagnosed psychiatric illness, but stressors and other things that don't necessarily have a name, but are definitely affecting people. A third of students say they've been bullied. 1 in 6 say that they've thought of suicide in the past year. Many have had experiences of self-harm, whether with an intention to die or just to feel or to not feel. It's complex. So we can't meet youth where they're at if we're not meeting them with all of the myriad of developmental tasks and developmental challenges that they are facing, and not just asking, okay, what's your drug of choice? Here's your treatment options, but addressing all of these other issues as well. We will have an opportunity to talk a little bit and even, ask case examples if you want to at the end. I just thought I'd fill us up with a menu of a lot of stuff to discuss, to consider, to ponder. We'll go to the next slide. There have been a variety of great guidance documents. A number of years ago, the BCCSU produced the Youth Supplement to their Treatment for Opioid Use Disorders guideline. This youth supplement it's a great read. You can find it online. I can't remember how many pages it is anymore, but it's quite substantial. It's a bit dated, but it's not out of date at all. And it talks about how to have youth specific approaches, how to develop youth specific services, even within the context of wherever you're working. Like if a half day at your RAM clinic is just focused for youth, or if it's not divided up by days of the week, but just having youth focused approaches known to your staff, it's really helpful. This includes trauma-informed approaches. If any of you are looking for how do I help my organization become trauma-informed, we now know that there's a lot of resources for this. The one I love is Clinic out of Winnipeg, Clinic with a K. Clinic is a health center that somehow had the human and financial resources years ago to develop an online resource on helping your organization to become trauma informed, and it also has a patient or consumer platform to say what is trauma, how do I heal from trauma. So it's trauma-recovery.ca. In that, it's very Indigenous content worthy. It has a lot of great discussions on there. So it has a lot of culturally appropriate references. And some of us work in services where we're serving very specific cultural groups, for instance, in large urban centers like Toronto, and aligning with some of the services that are helpful to meet youth at those levels. Confidentiality. The confidentiality conversation needs to be explicit with this population. For many of them, this is the first time they're entering the healthcare system on their own. So they haven't heard the confidentiality statements before. They don't know what their rights are very often. You might assume that they do, and the ones who are savvy, you assume that they do, but many of them haven't heard that before. really important for youth, accessible one-stop shopping, wraparound services if you have them, or if you have a relationship with a community health center or some other service, youth-focused service that has that, develop those relationships. And shared decision making, we'll see that in the next slide. Some other groups have addressed this as well. Bringing in whoever is family to this person. That might not be their blood relations, it might be other people, and involving other people in their care. These people make a difference in positive outcomes. We know from surveys of, developmental surveys that show just one positive person in that young person's life can make a difference to positive outcomes. So bring that one positive person in. Remember that we sometimes want to use inpatient services with youth. We don't. I've been privileged to have a relationship working at St. Joseph's Hospital in Toronto in the past. I do not at this point, where we were able to bring youth into the child and adolescent mental health unit, even if their highest clinical issue was an addiction issue, because there are no clinical withdrawal units for adolescents in the province unless they've happened in the last 2 years that I don't know of. We can go to the next slide. There's a recent 2025 publication also out of BC on prioritization. So these are kind of pillars of approaching youth. In this case, they're talking about in opiate agonist treatment facilities, outpatient facilities, to make them youth-centered. Again, the first one is relationship-based priorities. Again, this goes back to rapport. Your therapeutic alliance is the most important tool in working with this individual. It's not so important that you get them on methadone the first day you meet them. It's important that they come back the second time. And that doesn't happen with just a methadone prescription. That happens because you've developed a relationship with them and you put all the emphasis in that first visit on developing relationship. Advocacy goes a long way. Pick up a phone, make a phone call for them, to their probation officer, to their whomever that might make a decision. Very accessible services are really important, not mandating that they have to have an appointment or that they have to have their OHIP card on the very first visit. Walk-ins are important. Bring yourself in. Let's see you, whatever you might have in the front lobby that might make it more accessible, like coffee or cookies or whatever that is there. Having a flexible approach, definitely shared decision making, really important. And trying to offer more services than just the core services. So wrapping around that there's also physical health services, mental health services. And if you don't have them under your roof, have them in the relationships that you've built. More and more so, we're allowed to refer to things like spiritual healing, well-being, in Western medicine. It's not been an easy journey to try and include that. I'm not talking about inviting religion in the room. That's not what I mean, of course, but including what's spiritually important to individuals and even families if they become involved in their care. And for people for whom that's culturally appropriate to include that, to more formally include it, whatever ceremony they might find important. We can go to the next slide. I've already addressed some of these things in terms of when we're working with the youth themselves, but you really need to involve the parent. In primary care physician or nurse practitioner practices, it's not uncommon that the first person to access the service is not the adolescent themselves, but their parent, who comes to you and says, especially if you're treating a whole family, right? If they're all in your family practice, who will come in and say, I think my daughter Abigail is on drugs, and I want you to see them. I want you to tell her that it's not safe to use them. This is a really awkward position to be in, right? First of all, I never knew what the phrase "on drugs" means, but I always found that an interesting term that parents seem to preferentially use. So we need to talk to the parents as well about confidentiality, resources for them, so that if their kid is not ready to come in or is pre-contemplated for change, that they have resources to support them, including ourselves as clinicians. Come and see me next week. It might take us 6 months before we get Abigail to come and see me, but let's talk with you. Getting them support in the community. and helping them to find out what treatment programs there are. In many parts of the province, there are services, adolescent addiction, mental health services, but a lot of these services include services that the parents can directly access, even if the teen is not accessing, over and beyond your own offerings that you can give. And again, shared decision making. We can go to the next slide. Um, so, some of the youth focused screening tools that I specifically want to talk about, you can find them online. This is an example of one place you can find them on the right side of your screen. Um, and many of you have heard of the CRAFT questionnaire. So, this is a questionnaire, what is it, a 6-question questionnaire that is specifically for screening out youth to see if they may have an alcohol or substance use issue. For the youth who comes in and says, you know, I blacked out last weekend at the school dance. My parents say I have a problem with alcohol. You don't have to pick up the CRAFT questionnaire. You've already got your information. But if you're working with a general population, this can be a great tool. SBIRT is screening, brief intervention, and referral to treatment. This is a often mentioned acronym or tool in American literature, primary care, emergency medicine, pediatric care. We haven't sort of adopted the nomenclature or this abbreviation, but we all do it. We all do this. We all ask a few questions, then give a little bit of advice or a little bit of motivational interviewing, and then often refer off to the RAM clinic or off to the pediatrician or off to the youth serving agency. So we all do it, but SBIRT is something you can read about as well as as a tool to use in your practice. If you want something more comprehensive and get to know the kid a whole lot more, and again, it doesn't have to be in the verbal exchange in your clinical appointment. This could be something that's done on an iPad in the waiting room. For the youth, or even on a piece of paper, old-fashioned, old school, on a clipboard. The HEADS assessment tool looks at far more parameters of their life. So some of those developmental tasks that we talked about. How are things at school? How are things at home? What's going on with your sleeping? What's going on with your appetite? A lot of different things. Other tools that can be really helpful is the tools that are formalized, like on an online questionnaire or on paper, for their readiness for change. Are they pre-contemplative or contemplative for change? Are they actually already engaged in change? You can also just do this informally by asking a few questions, right? For those of you whose primary practice is adult addiction, you know readiness for change sometimes without even asking the questions, don't you? You've been doing the work for so long, you can tell if somebody's ready for change. But adolescents don't tend to walk into your office and say, Doc, I mean, some of you, we've been in the business for so long, you remember this era. You know, I've been using heroin for 10 years. I want to be on methadone. Can you start me on methadone? So gone are the days of heroin. But not gone are the adults who walk in your office and say, I know exactly what's wrong. This is the treatment I want. Can you give that to me? And in this day and age, we have quote unquote methadone clinics or opiate agonist treatment clinics or RAM clinics that do exactly that. That's how the client, so to speak, rolls up, and that's what they get when they roll out the door. Adolescents don't show up that way, do they? I have to be here because my mom said I have to be here, or my probation officer said I had to be here, or I don't have a problem, but my girlfriend says I should come and talk to you, or I got admitted to the Emerge last night, now I have to come and see you. They don't come in looking for services in the same way, and they often don't present ready for change. And we're helping people to work through the stages of change with our, long acquired motivational interviewing skills. For those of us who are from my generation, we did not learn motivational interviewing in our medical training. We learned it on the job. We also learned it as parents, right? We also learned it as parents, partners, etc. We can go to the next slide. I hope I'm not speaking too quickly. I'm giving a lot of background. Many of you are already deeply immersed in this work. you've already integrated much of what I'm saying. It's a fresh opportunity to look at this and to stand back and think about some of these things and say, hey, I've been seeing youth for a long time, but I've never used the heads questionnaire. What a cool idea. Why don't I do that? Or, oh, maybe it's time for me to go back to YouTube and sharpen up on my motivational interviewing skills. Because you're right, the last youth I saw, that last 22-year-old I saw, he kind of dug his heels in when I suggested this or that. How do I work with someone who's pre-contemplative and is digging their heels in? So here's the territory that I think most of you on this call, I haven't gone back in to see who's joined as participants since we started the talk, but most of you that I recognize in the participant list there, you're very familiar with a lot of these tools. And I think we could get, depending on how many prescribers are on the phone, nurse practitioners and physicians, we may be having a more deep dive conversation about what choices we're making for pharmacotherapy. But as with other populations, the choices remain the same. Over the course of many decades of working with adolescents, I have gone the abstinent route, supporting abstinence and giving just pharmacotherapy that helps people to withdraw from opioids, let's use as an example, or alcohol. Not too many adolescents have an established enough alcohol use career to go into withdrawal, but some do. So I have worked with many around abstinence or going to abstinence-based treatment facilities. Less so than an adult, more so than an adults, right? But also less so now than we did 5, 7, 8, 10 years ago, because just one re-exposure to the opioids that are out there now is extremely high risk for death. So less often do I have the conversation about an abstinence pathway that I did in the past, more often with parents who that's what they want, often is abstinence. And sometimes you're just treating withdrawal, you're just supporting withdrawal symptoms. And we have more options on the menu, don't we? Slow release oral morphine, safer opioid supplies, or using SOS as a taper, not usually to abstinence, but sometimes to opiate agonist treatment. And then, of course, opiate substitution treatment itself. More so in the young population with buprenorphine. In the region where I work in northwestern Ontario, in the fly-in communities, the only opiate agonist treatment option is buprenorphine. So sometimes based on the setting in which you're working, the choices are limited. But the literature much more supports buprenorphine for the adolescent population for a lot of pharmacologic reasons, for a lot of non-pharmacologic reasons, for a lot of patient preference reasons. And then, of course, there's also provider preference reasons, right? Despite all of that, there are some for whom methadone is the most appropriate opiate agonist treatment. Lest we forget that. We should not forget that. And as far as non-pharmacotherapy interventions go, please think about this broader sphere, not just of our options on the left-hand column, but of offering primary care, mental health care, access to psychiatric assessments, using all the tools that we have robustly collected over our careers of motivational interviewing, trauma-informed support, and use those resources out in the communities, particularly those youth mental health agencies, those youth addiction agencies that can support them. Sadly, in many parts of the province, those are two separate organizations still. They're still very siloed often. Not always, but often they're quite siloed. And then referral to all the social services as well, right? What hope is there of stabilizing your opiate use disorder if you're homeless and you're making your income on the street, right? So getting people back to one of the primary developmental tasks of adolescence, and that's education, getting them back to school. These are really important. We might be revisiting some of what came up in this slide here, as the preference was to have more of the questions and discussions at the end. So we might come back to some of this. So, and please make suggestions if there's more I should be adding to these slides, because Mike Franklin and I will be presenting from some of the information from these slides when we present on a youth-specific program he works in Sudbury at the conference this year. So we'll go to the next slide. If you like to read, say, I'm an old-fashioned girl. I have these books and many more actually on my shelves, and I've read both of these. So the original motivational interviewing, heroes, Miller and Rolnick, and the work that they did, adapting that to primary care settings and how you help change in primary care. But this is the third edition of their primary book, right? Of their foundational work, and then they've adapted that to many different settings. And then here's an author that took their original work and adapted to adolescents and young adults. This third item here is actually extremely dated now, but it's one of my favorite, just 3-pagers on motivational interviewing for adolescents. And at the bottom I've included there's lots and lots of YouTubes. If you look up SBIRT, like screening, brief intervention, and referral to treatment, you'll find a lot of great videos that include the motivational interviewing that is incorporated into brief interventions. Or if you just Google motivational interviewing with adolescents, you'll see that many of them are for parole officers, for teachers, for emerge docs, for different settings, right? So you too can learn motivational interviewing online, but really the most robust way to learn it is to practice it either in a course or with your kids or whoever else you're trying to motivate. This is a foundational tool for working with young people. We'll go to the next slide. I think cognitive behavioral therapy is too, and many people have incorporated many of the tools of cognitive behavioral therapy over time. But often we rely on specialists out in the field who do this work full time, right? I've posted a few here from different parts of the province that provide inpatient or outpatient youth-focused services in mental health or in drug and alcohol counseling. I think the Connects Ontario still is the host. You know what? I haven't used it in a long time, right, to look up resources. But when the average physician, nurse practitioner, parent, whomever is trying to look up community resources in Ontario, anybody correct me if I'm wrong, I think it's still Connects Ontario that you go to. But you may just know your local services, right? Down in the corner here, CAMH. CAMH now has, I think it's the first ever youth-specific RAM clinic in downtown Toronto. And St. Joe's Hospital has, I think, still the only transitional age youth, meaning not your child and adolescent psych unit, inpatient psych unit up until age 18th birthday, but transitional age, so from 16 and I think they go to 27. Waypoint in Midland has an outpatient transitional age youth program. Many of the mental health agencies in the province, including in Toronto, have transitional age youth groups, so they go up to ages higher than you might anticipate, some up to 27, some up to 29. The upper end of transitional age youth is a little bit fluid in different parts of and different organizations. There are, and I haven't included any of them here, actually, Indigenous specific inpatient facilities, outpatient facilities that would be overseen or largely organized through the national umbrella organization of the Thunderbird Partnership Foundation. So depending on where you are in the province or which part of the population you're working with, there are even more resources. Get to know the ones in your neighborhood. We all get so busy in our day-to-day work and oh my gosh, the sheer overload of documentation online and on paper that, we don't get out to some of these agencies right in our neighborhoods or serving our populations. And These are great resources to know about. And how do you get one of your patients' foot in the door? We can go to the next slide. I think this is my final slide. This is the slide I've been finishing with. I haven't done talks in a long time, but there was an era when I did a lot, and I used this slide whenever I was giving a youth talk um, for years, for decades. So whatever agency you remember is in your area or not, whatever motivational interviewing tools you remember or not, however comfortable you feel working with an adolescent or not, or they're telling you about substances that they get online that you've never even heard of and you feel embarrassed, really, all of that jargon does not matter. But if you can convey to them, I care about you, I am concerned about you, I will be here for you, my door remains open for you, then they'll come back. And if they come back, you can build and build and build and build. And even the pre-contemplative kid will one day say, hey, can you help me with this? Or can you help me with that? Or can I work on this? Or can you refer me to there? So this is the medicine, right? This is the most important medicine you're going to offer. And that is therapeutic alliance, rapport, advocacy, believing in this kid, slowing down so that you can do the work with them. I see all of you sharing some thoughts on the chat, which is fantastic. I don't know what happens next, Jen, if we go to a gallery view or if there's some way to share. Yeah, great. I don't see everybody, but I see you and me.
Yeah, I don't think we have a way of seeing everybody. Laura, you can correct me if I'm wrong.
Yeah, I think that's right.
Yeah, but as we've said, anybody can put their hand up and Lori will unmute you and please feel free to ask questions or share experiences and resources. It sounds like, Sharon, you've shared a lot and others have in the chat as well, but great to hear about what people have found in terms of what's around. I might just start on that note, and I hope people will add questions and comments. I have lots of my own to get us started. Um, I find that um, both youth and parents talk about treatment. Got to go to treatment. I want to go to treatment. And um, needless to say, there's a dearth of accessible, let alone evidence-based sort of treatment, meaning sort of residential or bed-based treatment for youth.
Yeah.
I'm wondering if you could share a little bit about your thoughts on, when is it the right option, for whom, how to kind of diffuse that sense of importance of treatment.
Yeah, I mean, that's as specific as each youth in each moment in time that they
Mhm.
present. And of course, the agenda of the parents around them, right? Or the adults around them. And that's not always parents, that's sometimes the group home they live in, the probation officer, whatever it is. So I'll give you an example, and I think our audience members are going to give us an example, right? Give us their examples, and I want to be sensitive that some people bring examples because of how precious adolescents are. A lot of people end up bringing examples that come from their personal life, and that's okay. You don't have to identify it, but that's okay because that often comes up in conversations. Um, so today I was in a case conference call with my colleagues up in one of the communities up north, and this is the mental health team. They're called the Choose Life team, and we were talking about a particular youth who is 14 years old, female, who started using alcohol at age 10, started using substances at age 11 in the company of her family members who use. And she has not been to school. She thinks the last grade she went to school was grade 5. Her family has been in chaos for many years, and she's had multiple visits to the nursing station with consumption of non-consumable alcohols. So I'm talking about perfumes and sprays, some of which in the community have led to very dire medical outcomes. And she has expressed that she wants to go to treatment. the North is very fortunate with something that the South doesn't know about. It's this beautiful, uh, it's not a kept secret, it's an open secret. And that's that there is family treatment in the North. This is a precious, precious gift. But anyway, this family, the mother doesn't want to go to treatment because she has a son who is socially isolated and won't come out of his room, and she can't leave him, and he won't go to any public place. So she's saying that her daughter can go to treatment. She's finally given us the room and the space. So she's gone to one of the places that was mentioned in the comments, or not gone. We've applied for her to go there. And the comment I said today was, this young person is so blessed that she can get the paperwork done to go to this program, that this program exists for girls her age, and in the North, that is culturally appropriate and that will allow her to socialize. They're going to have a school program. They have a school program there. She's going to go to school for the first time in how many years? She's going to socialize with other kids her age. She's going to be in a social milieu where people are talking about being well and getting healthy and thinking about your future. Things that her family at this time in their journey don't have the resources for. So for her, going to treatment is going to be, I think, a magnificent opportunity for her life to look very different than it would have otherwise looked like. Is going treatment for, I'm going to use some cliches here, right? The urban kid, the suburban kid that I see when I used to work at St. Joe's, who lives in his family home and families going maybe, let's say, through a separation or some other family crisis that's been going on for a year or so. He's still attending school. He's not getting the marks that he used to. Mom's really, really agitated and upset that he's been going out drinking with his buddies because the reason why she's having marital difficulties with her husband is because he's a drinker. Does that kid have to go to treatment? No. If the universe was willing, there would be family treatment in Southern Ontario, and the whole family should go, or at least mom and dad should go, but that doesn't exist. And then the canary in the coal mine is the kid who gets told, you're the pathology, you have to go, you have to go to treatment. I don't know. Maybe if that teenager is really struggling in school and dad's beating him up and nobody's going to disclose that, and this is the only way to pull him out of that environment, then maybe the answer is yes. But maybe the answer is no if he's actually doing okay at school, not getting the A's and B's that he used to, but he's actually doing okay. He's actually, playing on the basketball team, or he's got a girlfriend that is his one focus of sobriety and wellness, then no, right? Like what's the magic fairy dust that's going to happen at treatment that makes it so important? Well, what it is alleviating mom's anxiety. She's scared to death that her kid is going to turn out like her husband, who she's now very angry with. I'm giving an amalgamation of scenarios, right? Yeah. So probably in that scenario, mom needs support. Mom needs a lot of wraparound support. Maybe mom and dad need a referral or some support to go to marital therapy. Maybe they need, in my jurisdiction, we would refer them to the Breakaway Family and Youth Alcohol and Substance Use Services, where they do a lot of the work with the parents before they even meet the youth. So I'm using two examples to say why it might be yes, why it might be no. But I'm sure all of us have had have had real experiences in our practices, but also in our families, right? Where this comes up.
So, I mean, you've touched on this already, but Sarah in the chat asked, what about when that young girl that you referred to returns to her family home? What supports will be there for her? And obviously, you've shared different kinds of scenarios, but the questions are the same, and it's the challenge of taking someone out of the home to go to treatment is coming back into an environment if things haven't changed there.
Yeah, this is huge. I mean, in many of the services for Indigenous community members, some of the incredibleness of the resources are that people can go to some of these programs for 3 months, 6 months. We've had families who have gone to treatment for a year. Not we've had, that's the wrong verb to use. I have worked with families who have gone to treatment for a year. So sometimes they're not coming back to the same environment, but when they do, yeah, a lot of preparation, making sure you've been in contact with the treatment program and talk to the discharge planner, talk to the team about how's this person doing, what are the resources they're using, what can we work with them, how can we work with them when they come back to the community, and try to keep them resourced but in an outpatient setting when they come back to the community. But ultimately families make their own decisions, right? And it's not our role to intrude in family decisions unless there's child protection issues. So sometimes the reality is that kids go back to very similar environments. The example that I refer to, the mother is actually in the opiate agonist treatment program in the community where I work, and so working with her to help stabilize her opioid use disorder issues, and helping and the Choose Life team wants to then, once this child that has been coming into the nursing station with repeated overdoses, or use of perfumes and so on, is that maybe then we can start working with the socially isolated child, and so mom is not so worried about that kid who won't come out of his room. Yeah, there's no magic answers to that, right? You do the best you can, but we all have to maintain those communications, because often people go off to treatment and then we just, we say, oh, that's great, they're away at treatment, and we don't maintain the continuity of getting updates and preparing for when they come back. So that we can do.
I'm hoping people will put other questions and comments in the chat or raise hands. And if I miss you, give a little wave or a shout in the chat. I'm still thinking about the family situation and dynamics. I'm thinking now in my, as you say, sort of, urban, suburban practice, not in the north per se, although I guess similar dynamics around confidentiality. And you touched on that a little bit. So, the parent wants to share information, but they don't want you to tell the child what you know from them or about their worries, or they want you to pass messages. Obviously, kids have a very different perspective on their parents' behaviors and worries or challenges in and of themselves. Having parents in the room, not in the room. You've been at this for so long. I'd love to hear some of your stories or your strategies for navigating those challenges.
That's a great question.
And I'll share, sorry, just something for you to think about what you're talking about, sort of the ultimate, right? The parent wanting urine drug testing or some kind of testing for the kid.
Yeah, not an infrequent request. So
Yeah.
I think it depends on the setting. So when I worked at St. Joe's, I was embedded in the child and adolescent mental health team. So I would see the youth when they came to the emerge, when they were up in the inpatient unit with their mental health issues, and then I would follow them as outpatients. So, but as blanket statements, so it really depends on your setting. So versus my family practice, that would be very different, right? But my again, the primary tool is the rapport and the therapeutic alliance I develop with the youth. If I'm going to maintain that, I have to protect it. So I have allyship with the youth. They are my patient. Now, in a family practice, so in the hospital setting, the parents are not my patient. The child is my patient. In a family practice, that changes, and my allegiance has to be equal, right? And I have to think about all of that. But I always see the youth as my focus of my allegiance and my allyship. I don't lie to parents, I don't lie to the youth, but I do lean on the side of protecting the youth's integrity. Again, it depends on their age and their maturity. If they're 11, it's very different than when they're 16, right? When they're 16, there's very little the parents are getting out of me. Very little, unless the kid says so, or unless there's something extremely high risk, right? Very little. 11, that changes completely, right? Well, most of you on this call know me. I'm fairly straightforward. I'm transparent. I'm blunt. I will say to the parents, no, no, I can't share that with you. There's no way I can continue to work with your child if you're asking me to divulge this. I also was really clear about not taking email correspondence from the parents, because parents will write 3-page emails about how horrible Friday night was. You have no idea what it's like to deal with Johnny when he's blah, blah, blah. I do because I've had teenagers, and I do because I've heard these stories many, many times. I don't need to hear the email that's this long. And often I'm getting not only too many details, I'm getting information that I should not be hearing about their family system. So I limit the like I don't allow emails for anything other than correspondence of dates and times that people have their appointments. I don't and also the admin staff that I work with know not to. If a parent phones and says, "Did Michael make it to their appointment?" I'm sorry, I can't tell you that. If they're 11, of course I tell them that. But if they're 11, I expect their parents to come with them. If there's stuff I think the parents need to hear, and the youth is reluctant, I will say, let's bring them in the room, and maybe that will take 2 or 3 visits before the youth is okay with that. But transparency is I almost always lean towards transparency. I don't think secrets are helpful. There are appropriate secrets, though. Like the 11-year-old doesn't need to know that the mom is angry that the dad is having an affair. That's not necessary information to be known in the healthcare relationships that I'm building. That can be known if it needs to be known in a different way. Urine drug screening, if I think there's any clinical advantage for the kid, I will promote it to them and say, hey, listen, I think your court case is going to go much better if we give them some physical evidence of how well you're doing. I can only release the urine drug screens that you give me permission to release. Depending on the youth scenario, and by and large, I'm fine with only releasing the urine drug screens that weigh in the favor of the youth's positive outcome with the judicial system. There's not too many times I'm pro stay in the judicial system. There have been street youth that I've worked with where they were sometimes better off in jail for a little while, cooling off and getting fed and sleeping. But there's not too many times I'm going to weigh in favor of doing the proper thing. I'm willing to give only the information that the youth allows me to disclose, but not when there's safety issues. Public safety issues, other safety issues with other kids in the home. So it's very case by case, and you might have a specific case in your mind, or even other people that are listening to this might have particular scenarios that they recall. But those are my general ways I make the decision. If I'm in family practice, the best way to address that is just to have everybody in the room at the same time. Have the adult and the child in the room at the same time. I think the closer and closer they get to 14, the more emancipated I see them as being. Some are very emancipated already at 13, so they can make those calls about whether that parent is in the room. And then I think if anybody has a specific example that they want to bring up, I'd as much enjoy to hear from everybody on this call about how they would do it. But those are my generalities, I think. I think I've hit most of what you asked about.
I always have some scenarios, but I agree. I love for other people to bring them up. I'm curious about your sort of 14, thinking about, I know it's not a hard and fast cutoff. You're obviously looking at, understanding, comprehension, judgment, all of those kinds of things, but you sort of threw that number out there. So I'm going to ask if 14 comes from something.
Yeah, I think it comes from having been in the business for 30 years, and the legislation has changed over time, hasn't it? Ages of consent has changed over time. Reporting ages haven't really changed over time, but 14 has loosely been used as sort of an age of medical decision making, emancipation, but our laws don't suggest that it needs to be 14, right? It's a judgment call, but I've kind of loosely used that in my brain. But yeah, again, it's so much about the setting. When I worked with homeless and street involved youth at the show clinic, if they told us they were under 16, we were often obliged to report them, because a person under 16 ought to be reported if they're out on the streets, right? Certainly youth hostels report them if they're under 16, but many of them were under 16. They just knew to tell me that they were over 16. So, but the freedom there was, most of them were sadly and tragically emancipated from their parents, telling us that they were 16. So we just didn't even take these things into consideration. We made decisions. So again, the setting makes a huge difference. I don't know. It's a good question, Jen. Why do I use 14? I don't know. I think I use maturity and the level of conversation I'm having. When I'm actually in the room with a kid, that's probably the marker I use way more than an actual number. But as you're asking me in an academic sort of presentation setting, my brain is using 14. Yeah.
Yeah. I mean, I fully recognize that you are using all of your skills to determine the ability of that child to understand and comprehend and
Yeah.
make big decisions. I'm conscious at the same time thinking about, other scenarios and presentations about parents who would say, no way that child has the capacity to make appropriate decisions, right? Um, and the more difficulty that kid gets into, the more convinced the parents are, probably that they need to be more involved and have some other tools, right? To again,
Yeah, I've had more than enough conversations with kids who weren't seeing eye to eye with their parents when I said, you know what, dude? Your life is going to be so much easier if you just let your mom in the room.
mm,
Not for me, but for your sake, man. Like, your whole car ride home is going to suck if you don't let your mom in the room. She's gonna want to ground you or keep you in on Friday night. Why'd you let her in the room? All she needs to hear is a bit of smart thinking from you. How about we
mm.
talk about that? Like, can you give her, a bit of smart thinking that she can hear from you? And so that's where I kind of use my allyship with them to help the parents' agenda, because I'm feeling the parents' agenda all the time. In the era when I worked at St. Joe's, it was when I was raising my kids, and it wasn't even that. It wasn't an isolated incident when some of the parents were my kids' peers' parents. So I mean, I felt their pain, right? So I was doing a lot of, I don't know. I don't think that was colluding. I think it was, you know,
Strategizing.
tricky navigating of through, into their lane, into the parents' lane, into the kids' lane, into the parents' lane, and try to get us all to steer forward. I think, yeah, I've used that tactic.
I mean, it all seems very consistent with your approach around, building relationship first, foremost, and all the way through.
Yeah,
Could we talk about attention deficit disorder,
yeah,
impulsivity, and sort of what that means in terms of substance use risks? Parents obviously have concerns about using medication for ADD. They fear that that somehow increases the risk of substance use. And of course, there are concerns about, there's over medication, concerns about medications. You've seen it all.
yeah. What an interesting territory, right? Because now we live in an era where there are ADHD specialized clinics, with some of them, I don't know if you refer to them as for profit, but they're expensive to access their services, right?
And
And
some
yet,
online that are not expensive at all, where you wonder what
exactly,
kind of assessment is being done for a prescription.
right? Or the pediatric psychiatrist who has a 2-year long wait to see them, who is a self-identified specialist in ADHD. All this is the cynical side of Sharon, right? All for a very subjective diagnosis, as are the majority of mental health diagnoses, right? They're subjective. There's very little objective data. We can say that the Weiss scale and the other scales that we use for measuring ADHD are objective data, but they're based on subjective information. It's a very subjective diagnosis, and how do you make that diagnosis now versus 20 years ago. I would have been much more comfortable answering this question 20 years ago before everybody's brain was so, affected by, by the cognitive pixels that we now live in, right? And our foreshortened attention span. Mine is foreshortened. And then with our ever increasing interest, curiosity, capacity, and confusion to understand what is neurodiversity. Oh, so now ADHD is on the neurodiversity spectrum. Oh, okay, and that's all on the spectrum with a whole bunch of other things now. So this is changing. And how do you differentiate ADHD from the traumatized youth's brain, or from the neurodiverse traumatized youth's brain? I do know. So there's a lot more questions than answers. One answer I am certain of is the child who has undiagnosed, and in this case we're talking about ADHD, undiagnosed ADHD, who sits in the classroom with an internal experience of being different than everybody else in the classroom, and certainly not on the same page as the teacher, and especially if it goes on year after year, is a devastating impact on neurodevelopment, and especially the social developmental tasks that are so important. They just feel so othered. They feel so different. They're highly more inclined to depression, to anxiety, to non-social fitting, and these are the adults that get diagnosed later and go, oh my God, why isn't this stimulant in the water? Why didn't anybody tell me about this before? Now, there was an era where that was a big population we were talking about, right? All these young people that weren't noticed. Now, of course, we've gone into the other spectrum where we're having over-diagnosis. But I definitely remember that from my years at St. Joe's, the kid who never got seen with their ADHD brain and had lost so much traction in their neurodevelopmental tasks. Devastating to see. They still exist, right? Those kids still exist in cultural groups that are not comfortable with accessing assessment tools, or with accessing mental health diagnosis, or with taking pills. And it's not just cultural groups. There's other groups that that are in pocketed deserts for getting assessed. Yeah. But overdiagnosis is also an issue, and the literature changes over time as we look at so many intersectionalities. Like I said, neurodiversity, other things, right? Trauma, other things. As to does that also put them at a higher risk for substance use issues? Usually, you, I, and most of us on this call are seeing people when the substance use issue is already presenting, not when we're trying to prevent it. And all of that discussion, does it put them at increased risk? I would say it probably does, but I'm not the researcher to give that data. I think there's data that also says that's not the case, but there certainly is a lot of data suggesting that there is. I guess what I'm saying is it's not an easy territory. I'm willing to make the diagnosis of ADHD. I'm also willing to refer people to the places that do that. I really, particular in younger ones, really try to promote the non-pharmacologic interventions, like keeping a day planner, whether it's on paper or online, having organized tasks that you achieve during the day, aligning with your parents or with another mentor, an ADHD mentor, or somebody that helps to keep you on track. These, time keeping on your phone. The words aren't coming to me. When you have beeps go that remind you of things, reminders on your phone, things like that. And I don't shy away from the pharmacotherapy as long as I can follow up with the individual and make sure that I'm monitoring them for response to treatment, and that they don't end up on indefinite stimulants without anybody keeping an eye on how that's going. That's a surefire recipe for harm to them or to somebody else who's going to access those stimulants.
There is a question, again, you sort of touched on it, but where to refer an adult or adolescent for comprehensive assessment, I guess for ADHD or other um, sort of learning or neurodiversity issues without paying thousands of dollars. That might depend on where you are, Sarah. I'm not sure. So, Sharon, you might have some resources to share, but others in the chat might be able to kind of chime in with resources that they're using.
Sarah, I don't know where you're located, but there are family doctors that are good or even have focused practice in this. There are child and adolescent psychiatrists who are good or who have focused practice in this. You have to find them. You ask around to all your clinician colleagues until you find your
Yeah.
people. Just like you find your favorite gastroenterologist who will, do a scope for this or that, or your favorite nurse practitioner who is really good at obesity care, or will prescribe that Ozempic that the family doctor that you work with won't, right? We have all of these, we find these colleagues in our local area. So I don't know where Sarah is, and honestly, I don't know the Toronto market as well as I used to because I'm mostly working up north, and they're just out of sheer necessity. It's mostly the family doctors that are doing it.
Yeah.
Does anybody have a response for Sarah? Who?
So she's in Niagara. I mean, I don't know what there is in terms of Hamilton and GEO and mental health there as a starting point, or if there's anybody on the call from that region. Here in Toronto, again, waiting lists, but sick kids. I thought I saw Susan Franchuk on the call. I've sort of had, I feel like mixed information about whether CAMH is a place to get that, not as the primary focus, but whether those assessments are being done there. But many psychiatrists aren't. And so without the means to get a psychologist doing a psychoeducational assessment, it is challenging. And you're right, we're relying on the various kind of questionnaires and collateral information, right?
Yeah, and I think so. There's a lot of online psychiatrists, right? If you go through, oh, what am I trying to think? What's the platform? See, I don't use
Like
these things up
OTN,
north. Yeah,
like an
OTN.
OTN.
On OTN, there's a lot of psychiatrists, and you can actually see what their specialties are. And
Mhm.
I bet you the ones that are interested in doing ADHD assessments have that right beside their name. So
Mhm.
OTN is a place to even look for specialists, so they don't have to be geographically close to you,
Yeah.
even, right?
Yeah. Um, I clearly can keep asking questions if anyone wants to. So I will for another couple of minutes, unless anyone has other thoughts. I'm back onto the question of opioid use disorder and OAT, and maybe not so much about the specific of buprenorphine versus methadone. I think again, like the literature is relatively clear that when possible, buprenorphine is a first choice. There's lots of good reasons for that, but it's not necessarily going to work for everybody.
Right.
And we need to engage people. I guess I'm really thinking about the parameters of care. You talked about being, accessible, low barrier, less structured. Um, Kind of goes against a lot of OAT care, which needs consistency and structure, right? In
Yeah.
terms of, well, safety, right? And the medication working overall. And of course, is not the be all and end all for anybody, but especially for youth who have a substance use disorder. So I guess I'm wondering again about sort of, tricks of the trade from your practice, now and in past around engaging youth in OAT and the other supports to make it really effective.
So in northern communities, it's just so completely different from an urban center. Mothers and aunties bring in the teenagers. Mothers and aunties who you know, um, have used their opioids in front of their teenagers, and know, or their teenagers have used in front of them, and they can see right in front of them, and there's an open discourse. There's not in many of these families not and there's a healthy support to come and access care. There's not a lot of stigma within the family anyway to come and access that care, and they'll come with their aunties, or the Choose Life mental health team will identify them, and or the nurses will have seen them in the nursing station for an emergency, and they'll say, can you see them? So that's a very different access, points of entry to care. In Toronto, I've mostly done opiate agonist treatment for youth in private practice, but a private practice that was very resourced with front desk staff that were really great with young people and very adaptable to whenever, however they showed up, but only in open hours, only in business hours. And I worked with the Breakaway. Breakaway had a youth outreach worker whose job it was to work for Breakaway and find the youth around the city who had opioid use disorders. And that outreach worker would identify different practices where the youth could access care. And this outreach worker often would bring them to the practice that I worked in. And I had lots of relationships with both the inpatient unit at St. Joe's, with child and adolescent mental health unit. So I would just pick up the phone and get them this resource, or a housing worker, or a family reunification worker, or inpatient admission at St. Joe's. So the relationships were not bricks and mortar all under one roof, but just a phone call away to help them get those kinds of wraparound services. There's a part of me that's saying, Sharon, you're not answering the question. I've strayed from the question, haven't I?
It's all part of the question. I guess I have a particular sort of youth in mind, who's at home uh, on Katie and on SROM as OAT, not
Right,
in school, not working, not engaged with much else.
right.
Sometimes, like not getting to the pharmacy because how is he going to get to the pharmacy, or is he waiting for family? And, thankfully, eventually, reducing and moving away from unregulated opioid use, but not doing much else for quite a long time.
Yeah. So this is where I was blessed with these relationships with the outreach workers, and I saw the backbone of their treatment as the non-pharmacologic interventions.
Mhm.
And the outreach worker would meet them in coffee shops and build relationships and build relationships and build relationship until they could eventually get them to access the other services, like including myself as the prescriber, but also the return to school support, access support, whatever that was going to be, help them get into the George Brown, reentry program, or this outreach worker that was really focused on working with youth, beyond the parameters of just getting them a pharmacologic intervention is how I, and then I would find some way to get the parents involved. I mean, if a youth in highly resourced Toronto is staying isolated in their bedroom and barely making it to the pharmacy to pick up their dose of something that keeps them out of withdrawal, I really want to meet that family. Or I want to meet whoever is most significant to that young person. It might be their girlfriend, it might be their online friend in Russia. Let's get that online friend on Russia online and sit together, the three of us, and talk. I'd have to feel out over time if that is a healthy support network, but people have all kinds of systems these days, right, of who their support networks is, because obviously they're quite shut down. Even when you tell me that their pharmacotherapy choice is Cadian, that suggests to me a certain readiness for change. If you want to get back into school and get back with your peers and do things again, you're probably at the most using Cadian as a bridge to get to the next step, to get to something that is socially functional enough that I can re-engage in life. So I'm guessing this person has a certain amount of their internal system that's quite shut down, and that's their way of coping with their present situation and whatever brought them to their present situation. So I'd like to find whatever resources help that person to open up just a little bit, just safely enough for them, but just open up a little bit, a little bit, a little bit, a little bit. And when I was working, when my compass wasn't always pointed north for work, I would see them twice a week, often, and I would make the pharmacy, close to where we were, so they were coming out of the house anyway, and could come and see us. Those were a few tricks. Of course, you'd have to know the specific. I'm often a person. Okay, let's call your mom. Let's call your mom together. No, 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 no. and then find some carrot why it might be
Mhm.
worth their while that we would call them up. And then you're hearing, oh yeah, no, like he's got this and he's got that, but oh, okay, well, we could take advantage of this and that. And all of a sudden you've got a lot more information about what goes on in the family.
Mhm.
Um, yeah, there's a few ideas. I saw something else pop up there too, Jen.
There was a pop-up question about Supplicate, Bupixar in you.
Yeah, why
That's the
not?
question, not much more
Yeah.
detail in terms of the specific scenario.
Yeah.
Yeah, good, bad, or indifferent.
Whatever
Mhm.
works, right? Whatever works. But most importantly, whatever gets you back to the tasks of being an adolescent,
Mhm.
to the challenges of being a youth, to the joys of reimagining that there's a future for you and not
Yeah,
just this stuck place. Whatever it takes, man. If that's Sublocade, then it's Sublocade, right? If it's Cadian, then it's Cadian. But let's ultimately Cadian is has its limitations. And this is not a hate on for one modality or another. It's just like you want to use the modality that most allows you to realign with getting back to being a teenager, getting back to be a young adult, hoping for future, believing in future, enjoying, laughing, giggling, all those things, right? So whatever it takes.
yeah, which I would say is probably Bupixar, right? Not needing to be going to a pharmacy, taking a
Yeah.
medication, and yet also being protected. And that would be my experience with a few youth as hating the injection. There's so little subcutaneous fat on some of these young guys.
Yeah.
But knowing that they're being protected and feeling different and finding really good effect. Are there induction protocols for off-label use of Sublocade in youth under 16?
Yeah.
Um,
The protocol is go for it.
yeah, I don't
I
think
mean,
it.
I'm not trying to be silly, right? Like,
Yeah.
with appropriate clinical caution, appropriate patient selection, talking to another colleague about it, because you don't every day put somebody who's 14 onto Sublocade, right? But if that's what they need, then that's what they need, right? Yeah.
Yeah, I think you would want to have a really thorough conversation and document that,
Yeah.
obviously. So I
Yeah.
think the question is two-part, right? Just what about being under 16, but also any differences in terms of how to get people onto Sublocade faster, maybe. That's your question, Kamisha. And I think that's sort of, an area of emerging guidance, just around how quickly to do that, right? Whether to do a test dose or a cold dose. I guess I'm a little bit more conservative, especially in youth, about doing something that is off-label in many ways. So I might want to do some Suboxone personally before starting
Oh,
someone on
absolutely.
Sublocade. Yeah.
Yeah, absolutely. And I'm happy that they stay in my office for the whole day if that's what it takes before we, as we jump onto Suboxone and then go on to Sublocade. I'm happy if they take a Suboxone on the same day as a Sublocade. I don't have to be in a highly monitored setting like an emerge department to do that. Yeah, yeah, but I have really flexible. I have the tiniest of practice left in Toronto, but when we were much more busy, like when I was working with them a lot more, they're just they're so flexible. Our front desk staff, they're so great that they would make that easy for that youth to
Mhm.
stick around and we could do that. So not everybody has the benefit of working in a setting like that.
Yeah, that's amazing. Well, we made it to 8:30 with me asking all the questions. Thank
Um,
you. I want to say, as you were talking, I grabbed my, you can't see it, my motivational interviewing book.
Beautiful, yeah.
A classic I agree with pulling out and going through again. Always.
Yeah, yeah. And oh, hello to all the people that whose names I recognize, who are dear, and I care about you all. And thank you, because it's with all of you that I've learned to do this work. And for all the ones who I don't recognize, who I'm sure are enjoying this work as well, thank you all
Yeah.
for joining and enjoying this part of the population. I hope we see more youth RAM programs, and I mean they're also called youth. A lot of the youth hubs that are supported by CAMH do this work. Some do more, some do less of addictions work. They are an amazing resource, right? A lot of communities in Ontario have a youth hub. Find out if there's one close to you.
Yeah, and you can Google that, right? Like the YHO, I never quite understood. So Youth Wellness Hubs of Ontario. Again, there's more attention, more energy, and more money. Obviously, still lots and lots of need, challenges with service provision, but a great place to start. And there's generally psychiatry connection, right? Which is
Yes.
like that mental health piece that we I think understood implicitly is in the back of so much of what you're talking about. Um,
Yeah.
okay. Yeah.
Yeah.